My name is Marc Scheetz. I'm a professor of pharmacy and pharmacology at Midwestern University, where I direct the Pharmacometric Center of Excellence. Yeah, absolutely. So I was given the opportunity to really provide some updates on what's going on with PK/PD contemporarily. And I tried to focus on really just two aspects because there's always a lot going on. But two aspects where I thought that there are some newer developments. First would be with vancomycin. So with vancomycin, the guidelines had suggested that we should be moving to AUC-based dosing strategies. What that really means is looking at the total vancomycin exposure in your patients and trying to adjust them to the right levels for both efficacy as well as toxicity. And primarily, we're talking about toxicity at this point. The efficacy data haven't been as strong as the toxicity points. So with vancomycin, what we went over is that the toxicity data really are real. They really do predict quantitatively whether patients go on to develop kidney injury or do not develop kidney injury. And there's a very good mathematical relationship. At the end of the day, what it really means is that we should be giving our patients less vancomycin and targeting lower AUCs. And we started to go over those data. I can get more in depth on that if you'd like. The other aspect that we started to cover was with beta-lactams. So with beta-lactams, we have always known with beta-lactams that the way to optimize dosing for beta-lactams is to keep the free drug, so the amount that's not bound to protein, over the minimum inhibitory concentration of the bacteria that you're trying to treat. So that's been known for quite a while. What we talked about with beta-lactams, though, is an aspect that I think there's a little bit less appreciation for, and that is that our patients really have varying concentrations of beta-lactams and their ability to achieve those PK/PD targets. Most patients really have about 8 to 30-fold variability in their beta-lactam concentrations. And so what that means is if you're taking care of a patient on the wards and you're going from bed to bed to bed, you can really expect the concentrations for those patients that you are giving the same doses to. They look basically the same to you. They have the same creatinine clearances. They're the same age, the same type of patient. You're still seeing 8 to 30-fold differences in their concentrations. And that can lead to meaningful outcomes. So it's not something that's surprising to me, and it's really not surprising to most of my colleagues that are involved in pharmacometrics. But I do think it's surprising to most of our practitioners. I think myself and my colleagues, we have not done a great job really helping people understand how much variability there really is. One of the examples I usually give is that if you go to feed a group of, say, 30 people, it would be very odd to expect that you could serve one meal and have everybody really end up satisfied, right? So you're going to be dealing with food allergies, you're going to be dealing with preferences, you're going to be dealing with people who really require very different caloric needs. And so to expect that you're going to be able to put out a 750 calorie meal and expect most people to be satisfied is really just not possible. So vancomycin still is the most commonly utilized antibiotic in the hospital setting. And every time we present these data, people say, the new drugs are going to replace vancomycin. And we just largely haven't seen that over the years. I mean, vancomycin has been really in use since the 1950s, 1960s. So it has this very long tenure of being an antibiotic that is pretty resistant to resistance, if you will. We haven't seen a lot of resistance develop on vancomycin. But it does have its idiosyncrasies and it does have its toxicity. There are certainly drugs that are easier to dose, but I still don't think vancomycin is going away. There's just such a comfort level for many practitioners in dosing it, and it has this very long-standing history. So vancomycin is here to stay. One of the things that we reviewed were some data that we were able to get from a company called DoseMe, and they had a very large database. And what we were able to do was to take a look at that database. And when I got that database, there were about 35,000 patients per year. And so I started to just look at it by year because we had so much data. The one thing that we were able to demonstrate with that database is how much variability there is for people that are using troughs to guide their dosing. Now, the old vancomycin guidelines referenced trough categories, and what that means is when the concentration goes up, when you give your dose, you get your maximum concentration. We call that the peak, and then after it eliminates from the body, we call that the trough. Now, the old guidelines would reference trough concentrations that should be between 10 and 15 milligrams per liter for standard infections and 15 to 20 for your more serious infections and pneumonia. And what they found is that patients that had trough concentrations between 15 and 20 had additional kidney injury, really without any extra benefit, any good efficacy. And so there's still this long-standing practice. At the beginning of the session, I asked people, how many people are still using trough concentrations to guide your therapy? And a very large percentage of people were. It was about 50% of people were actually using trough concentrations to guide their therapy. And so now back to this data set that we had where we were looking at 35,000 patients per year. What we're able to show is that when you measure AUCs and you compare that to what the known trough concentrations are, there's really a very large variability. So somebody with a trough concentration of 15 would have a predicted AUC between 369 and 578. Now that sounds fantastic because that's right in the 400 to 600 range essentially, but that's for an exact trough concentration of 15. If you were to get a trough concentration of say 20, those patients had AUCs that were 480 to 692. So there were a lot of patients that were missing based on trough concentrations. One of the take homes, I think, is that trough concentrations do not line up with AUCs. Most of the data that suggests that they do really are just looking at a mean. What is the average patient experience? But what we're not really interested in means when we treat patients. We're interested in individuals. We're interested in the individual patient. So what we've been trying to do with some of our research and several other researchers in the field is to get people to quit thinking about treating averages and rather think about treating the individual patient. And for that, you really have to do therapeutic drug monitoring. So get the actual concentration from the patient you're treating. And then plus minus do some pharmacokinetic modeling with it to understand what your patient's overall exposures look like, not what they would be based on an average. One last thing I wanted to cover were some of the recent prospective trials for the beta-lactams. There's a lot of interesting findings that have come out, and all of our theoretical work really needs to be grounded in these experimental trials in patients. So two major trials I'd like to talk about really quickly. First is the MERCY trial, and the second is the follow-up to the BLING trial. First, the MERCY trial enrolled about 600 patients, and they were looking at whether patients got continuous infusion meropenem or intermittent infusion meropenem, something like over a half an hour or something like that. And this trial really found no difference between those two strategies. one thing that I'd like to note with that trial is that most of the patients that received meropenem probably couldn't have even benefited from the overall therapy. There were a good number of patients that had resistant organisms. There were a good number of patients that had no organism identified, so they may have not even had a bacterial infection. And to really get at a meaningful effect size, something like detect a 5% difference in mortality, you need a lot of patients. So you're not going to be able to do that with 600 patients. And when I calculated which patients could have even benefited, 86% of the patients in their trial couldn't have even really benefited from one strategy or the other because they weren't infected, or they had resistant organisms, or they had very susceptible organisms that you wouldn't expect to benefit. So very interesting trial, but I don't think that provides us a lot of information. The second trial that I'd like to talk about is the BLING III trial. So BLING 1, 2, 3. So this is the third series. You only get to the third series if the first two were good. And this was the one to end all the trials. It's not like Rocky. We're not expecting a BLING 5 or BLING 6 or a return like that. Hopefully BLING 3 is where it ends. And in Rocky, I don't think anybody liked Rocky 3. So BLING 3, this is the one that's supposed to be the better one, right? So this enrolled 7,000 patients into their trial. Again, this is a prolonged infusion trial versus a continuous infusion, intermittent infusion versus a continuous infusion. And what they did see is they did see a slight benefit in mortality. It also translates to about a 2% difference in mortality if they do their multivariate analysis at the end. The important thing is that there really is no safety concern with doing the prolonged infusion that they ran. So almost all of the findings that we would look at are leaning towards slight benefit. They saw an absolute benefit of 2%, and that's about what we would probably expect to be a real effect size by using prolonged infusion, a continuous infusion versus an intermittent infusion in a very sick patient population that has a lot of reasons to have failures other than just the antibiotics.